After understanding the etiology of DM, plus those mothers who are at risk, let us look at the clinical presentations. We have what we call acute symptoms. Acute symptoms, these are symptoms which come up promptly, and these mothers may report these symptoms to have occurred in less than 2 weeks. The first one is hyperglycemia. This results from decreased glucose entry into the cells. What does it mean? That the high carbohydrates taken through our meals are not broken down into smaller particles to be metabolized. So the glucose is released back to cells and there is no reabsorption. So it is taken back to cells and back to blood, and by examination we shall get RBSs which indicate hyperglycemia. Then another symptom is polyuria, that production of large volumes of dilute urine which is pale in color. Polydipsia, that is intense thirst due to excessive loss of fluid. Remember, this person has had polyuria. That means that there is a problem with the kidney, and due to a loss of lot of fluid, this person will feel thirsty. So that is polydipsia. Then polyphagia is increased appetite. Why is this patient getting an increased appetite? Because the glucose or the carbohydrates she's taking is not metabolized. Therefore, this person will tend to want to eat. And in the end of the day, this person will get a weight loss. Apart from eating a lot, the person will get a weight loss because there is no good breakdown of carbohydrates. And the body needs more carbohydrates. Then blood vision due to continuous loss of glucose depleting in the tissue of energy. This will eventually lead to impaired growth, increased susceptibility to infections, e.g. recurrent vaginal candidiasis and urinary tract infection, and then general tiredness. Then we go to chronic symptoms. Those are the symptoms which usually take quite a very long time, and these are due to vesicular damage from persistent hyperglycemia. And vesicular damage may lead to an organ damage. So on diagnosis, of course, we must start with the subjective data, that is history taking. And in history taking, the mother will tell you about the above. The mother will tell you that I'm urinating a lot, that is polyuria. I'm ever feeling thirst. I'm ever feeling hungry. But I feel I'm losing weight. So on history taking, and again, we have said that mothers at risk are those who may report even a history of DM in a family. So as you take the histories, this mother may tell you that some of his parents may be diabetic. So this is one of the clues for you to start thinking about the predisposition of diabetes mellitus in this pregnant mother. Then we go to the clinical examinations. That is the objective data. And of course, one of the key clinical examination is weight. We have said that one of the diabetes that is prone to obese people, yet another, they are losing weight. So weight may be a key factor in determination of diabetes mellitus. And after taking weight, we must calculate the BMI. to rule out either obesity or malnutrition. Then investigations, we take a random blood sugar, and we are saying that we will diagnose diabetes mellitus only if the fasting plasma glucose is greater than or equal to 106 milligrams per deciliter on at least 2 occasions. So we can take it now and we tell the mother to come back maybe after 2 weeks, then we retake it. But if it is persistently greater than 126 milligrams per deciliter, then we shall diagnose diabetes mellitus. So let's start on the management. How is this mother managed? Pre-pregnancy care. Here we are talking about a mother with a history of DM, that is basically diabetes mellitus type 1, type 2, and type 3. The insulin dependent and the non-insulin dependent DM. This mother is going to be planned to become pregnant. What do we do? So counseling the woman who are at risk of diabetes mellitus helps them to be aware of the complications which may occur. This is a pregnant mother. We have to make them aware of the conditions and how this condition may affect pregnancy or pregnancy affecting the condition, so they become aware. So this is very evident in mothers with a known history of diabetes mellitus. So all insulin-dependent diabetes of reproductive age should take adequate contraceptive precautions until they are ready for pregnancy. We have said there are those who are insulin dependent, and these mothers are chronically on insulin injection. So we should talk to them before pregnancy, such that they only get pregnant when they are ready to be pregnant. Then stress the need for pre-pregnancy counseling and planning. If they are on oral hypoglycemic drugs, they should be changed to parental drugs, as oral drugs may produce to fetal abnormalities. So this is also This is an insulin. This is mothers with non-insulin dependent DM, and they are on oral drugs, and when they become pregnant, they should be changed to parental drugs. Why? Parental, that is IV drugs, in order to minimize the chances of fetal abnormalities. Women should be taught to monitor their blood sugar, preferably using an electronic glucometer, and the aim is to maintain normal blood sugar. So a patient with chronic DM or with non-DM should always be advised to learn to know how to monitor their blood sugar. They are advised to buy glucometers and glucose sticks, and they learn to prick themselves in order to be able to monitor their glucose levels, and to know what to do. When glucose levels are high, what should I do? If they are very low, what should I do? And usually, some of these patients, they are told to move with sweets in their pockets in order to be able to manage when they go hypoglycemic. What do? They learn their diet, what should they eat, what shouldn't they eat. If they are collapsing, what should they do? So all these are education messages we should give to these mothers who present with a history of diabetes mellitus. So now when they become pregnant, these mothers should be managed by both a diabetic physician and an obstetrician. So if you are in a maternity center without a doctor less than 4, and you diagnose a mother pregnant or like gestational diabetes, this mother should be referred to a bigger health facility for better management. And then they start on their antenatal care. So if a mother comes to antenatal with histories which suspect DM, she's referred for hospital. That has been explained. And why this mother may be admitted. So it doesn't mean that the moment this mother is diagnosed DM, she's going to be admitted. But there might be some reasons which may lead you to admit this mother. One is stabilization to determine the dose of insulin, frequency, diet, and to monitor fetal growth. Remember, we said this mother is a non-DM. She's saying that she's on drugs, but when she becomes pregnant, we are going to change from oral drugs to parental drugs. And the parental drugs we are talking about is insulin. And now, we are going to admit this mother, one, to know what is the stabilization dose of insulin this mother is going to get, how frequent is she going to get it, how are her sugars fluctuating, so we are going to look at that for a few periods. Then we talk about her diet, and we also monitor the fetal growth. So during admission, blood sugar is taken twice daily, and if the blood sugar is 140 to 160 milligrams per deciliter, she can be managed on diet, which contains proteins, modulates starch, and sugars, and vitamins. So here we are going to advise on diet. And here, the diet will have a lot of proteins because the cells need to repair. And we shall advise this mother to have moderate of very small starch and sugars because the body needs energy and a lot of vitamins. So we are going to advise on diet, and then we shall plan the mode of delivery. And we are saying that maternal diabetes is not an indication for cesarean section, but its complications may be. It's not a must that which mother is DM is going to be admitted, is going to be delivered by cesarean section. But we look at the complications of DM, and most of the fetal complications of DM is fetal macrosomia, which occurs with increased frequency in DM, presumptively because of the fetal head size, but the trunk and the large, with these mothers are prone to shoulder distortions due to the big baby, etc. So if we anticipate this during antenatal, we have to continuously monitor fetal growth, fetal weight versus the maternal pelvis. And if we ascertain that this mother is having a big baby, it is preferred that this mother is prepared for a cesarean section early. However, current approaches of fetal estimating weight are the best. Current approaches, especially fetal surveillance methods, especially the ultrasound scan. So, what is the metabolic management of this mother? During labor, attention should be paid to the maintenance of maternal glycemia in order to lessen the likelihood maternal hypoglycemia in order to lessen the likelihood of neonatal glycemia. Remember, this baby is feeding on a lot of glucose through the placenta. So when this mother goes into hypoglycemia in labor, it is very likely that even the baby will go hypoglycemic. And in extreme cases, we should avoid ketoacidosis. Ketoacidosis is an emergency as a result of very low blood sugar. If this labor is to be induced, it is reasonable to begin early in the morning after the usual insulin and a snack the night before. If the patient's DM is well controlled, it can be anticipated that her fasting glucose levels will be within the target range. An intravenous line is established and infusion of 5% glucose in half normal saline. So here, because the mother is going to fast, this mother is going to be induced, it is preferably advised that we start in the morning, such that we can have the whole day being able to monitor this mother. Otherwise, in the night, the monitoring may not be very good. So that is why we start in the morning, and we shall put up an intravenous line to put up an oxytocic drip. But again, this mother should be maintained on 5% dextrose with half normal saline. So blood sugar is measured every 1 to 2 hours, and the target glucose level is 60 to 120 milligrams per deciliter. If this level is exceeded, an insulin infusion is begun, usually at the rate of 1 to 1.25 units per hour. Adjustment in the insulin infusion rate can be made if glucose falls below the target range or exceeds the target range. So this mother is on induction. We have said we start in the morning after ascertaining the normal blood sugars and after also giving her morning injection. And after doing that, we put up a maintenance rate of dextrose 5% versus half of normal saline. And then we continue to monitor the blood sugars. And it is very key that the blood sugar levels should be kept within 60 to 120 milligrams per deciliter. And if these levels exceed, it means if this mother goes into hyperglycemia, we shall put up an infusion of insulin in order to bring down the glucose levels. And we continue to monitor this mother during induction. And if the infusion, the glucose levels come low, we are going to put up glucose in order to maintain it back to the target range. If it exceeds, we go back. So the monitoring is very evident, such that we are maintained within the normal glucose levels. So if patient is to be admitted, for example, we diagnose the big baby for an elective Caesar, the elective cesarean section scheduled best, it should be done in the morning, not late in the night. So this mother will be advised to take a usual meal, a snack, and her insulin injection should be administered in the night before the morning she's going to theater. And blood glucose must be maintained in the normal ranges, that is 60 to 120 milligrams per deciliter. An intravenous line is initiated, and normal saline or some other non-glucose containing solution should be infused. Once delivery has been accomplished, glucose can be infused in order to maintain the saturating glucose levels.